Hi everyone. Hopefully you can hear me. My name's Logan. I'm one of the co-founders of Medicine for Essentials. Just comment in the chat if you can hear me. Or if not. So now you guys can hear me. Brilliant. Perfect. Great. So thank you so much for taking up your time to listen to our talk today. We've got a guest speaker in today, an ITU doctor who's going to go through vascular emergencies. But before we do that, we have a spokesperson from the Medical Protection Society, David. He's very kindly taken his time to come and give a 5-minute presentation on what's great about the NPS. I'm just going to hand over to David first, just for the first couple of minutes, and then we'll get into the talk. So just bear with us. Thank you so much, everyone. Cheers.
Thanks, Logan. Hi, everyone. Yeah, just taking a few minutes just to run you through who we are, what we do. Hopefully, a lot of you will have heard of us previously. My name's David Ricks, and I am a consultant relationship manager covering the south of England. Yeah, here to talk to you about our free student and F1 memberships with Medical Protection Society. So who are we? We are Medical Protection. We are a medical defence organisation, and our role is to protect healthcare professionals worldwide. We have over 300,000 members worldwide. I think I might actually be sharing the wrong screen. Let's see. Yeah, well, we'll make do. So yes, providing assistance with any medico-legal problems that might arise from your medical practice. The benefits to you guys at your stage of your career, of course, you won't be the clinician in overall charge at this stage, but there are a number of other benefits. So up to 25% off a wide range of medical textbooks, free foundation year 1 protection, the online learning, webinars, podcasts, and annual casebook. We've been doing a lot around COVID, obviously, over the last 12 years, but there's also some really useful stuff around dealing with difficult patients, the importance of case notes, everything you'd expect really to help you throughout your careers as you continue to progress. Medico-legal advice lines there 24/7 in an emergency. We're there to support you with any assistance with claims, complaints, disciplinary proceedings, GMC issues, and a lot more. Of course, you'll have NHS indemnity working in the NHS, but they don't protect you for those areas. So if you have a complaint to the GMC, they wouldn't support you. So we're there to be able to provide that assistance. So it only takes 60 seconds to sign up, which I'm told is as long as it takes to do a TikTok. It's free student membership. We're also having a prize draw at the moment for £183, which is a weekly draw, which is the average cost of student expenses and living expenses. So if you sign up to us, you'll be able to be entered into that draw. There's a QR code, which I'll pause on the next page. If you're not a member with us, follow the QR code and you'll be able to sign up. As I say, it only takes a few seconds. If you are an existing member, please do log in and refresh your details. It's really important that we're able to continue to contact you as you move from student addresses and student email addresses into the next stage of your career, so that we can keep your membership up to date and, as I say, provide any protection that you might need. Any SY5s will automatically renew onto the free F1 membership. If you have any questions following this talk, I'll be available for the next few minutes after this. You can also email student@medicalprotection.org. And if you're that way inclined, please do follow us on our various social channels that you can see here. But that's it for me for now. Thank you very much for your time and attention. I'll hand back to Logan and wish you a very enjoyable evening. All the best.
Thank you, David. Really appreciate that. I'm with the NPS and couldn't recommend it enough. So thank you so much. I'm going to hand over to Bilal, who is an ITU doctor. I'm going to try and share my screen. Bilal, do you want to try and share your screen first? And if we can't get it, I will try and get it up on mine. It's just taking a little bit longer than.
All right, let me just try to share it from here.
You.
Is it working? No, I don't think so.
Right.
I don't think it's working.
No problem. You can just give me 1 second, guys. So sorry. Sorry for the delay, guys. Just give me 1 second. I've got the. I'll try and share my screen in a couple of seconds.
Just a second. Let me try to sort this out.
Do you want to try and share your screen one more time, Bilal?
All right. Just a second. I'm logging in again. Let me see if that fixes the issue.
I'll try and share my screen.
Is it working?
I'm sharing my screen, so I'll just try and do this a bit slow. Apologies, guys. Can you see it?
All right, there it goes.
Yeah, I think I'm sharing. So just let me know whenever you want to move on.
All right, perfect. Hi, sorry for the delay. My name is Bilal. I'm one of the ITU doctors, and today is the third session of Foundations of a Junior Doctor series, and we're going to be talking about vascular emergencies today. So if I can just get the next slide, please. Oh, can I get the next? Okay. So before we start, we hope we can get some feedback about these talks, and you'll be getting a certificate within a week. There's a QR code given on the site and the link in case you can't access the QR code. Other than that, all the talks are going to be uploaded to YouTube eventually. And if you have any suggestions for any other topics, feel free to give them on. So now down to the main topic. So today we're going to be basically talking about some vascular emergencies, and we're just going to keep this a bit brief. We're going to talk about acute limb ischemia, aortic dissection, cervical artery dissection, and then we're going to have a small question and answer session. We're going to go on from there. So let's begin now. So the first thing we're going to talk about is acute limb ischemia. So given by the name of the game, the whole name of the term, we know that it means that there's a sudden or quickly developing decreased limb perfusion, which causes worsening symptoms or signs. And these symptoms and signs are often associated with limb viability. That means that if they're not treated in time, there's always a chance that we have to amputate the limb. Usually, this happens within 2 weeks of symptom onset. So the more common type is the acute lower limb incidence, which is 10 out of 100,000 approximately, compared to upper limb incidence, which is 3 out of 100,000. And considering that ischemia is involved and there's always a chance of losing the limb, it's a time-sensitive emergency. So even though acute limb ischemia can be caused by venous obstruction, but that would be very extensive and it's pretty rare, we're going to focus mostly on arterial obstruction. So a bit of a background. So there are basically two types. The first type is acute. Second type is acute on chronic and chronic, basically. Acute and chronic have been covered before, so we're mostly going to focus on the acute types. So they're broadly broken down into three types, three causes. The first one is thrombotic, which mostly is the main cause of these ischemic events. The second type is embolic, and the third type includes basically all other causes. So considering that this is a very time dependent, so as it's implied, it's very time dependent. So we're going to go on to the first type, which is the thrombotic type. So you see a small table on the right upper corner. All right, we're just going to go on to thrombosis. One slide back. You see basically a small corner in the upper top corner that gives us various mechanisms of how this might happen and some etiology of how this might happen. The first cause, embolism, that may be cardiac in origin or arterial in origin. Second type, thrombosis. Now, thrombosis can be due to grafts, it can be due to stents, or it can be due to the artery itself. And another cause is aneurysms. Because of the outbubbling, there's usually thrombosis present, and that it becomes a bit thrombotic, and that causes compression, and that further might cause ischemia. Even if a clot breaks down from there, it can go further down and cause ischemia. Third type is trauma. So trauma, we know, is one of the types that is one of the reasons why arterial flow can be disrupted, and it basically causes a very turbulent flow, and that can cause that. So trauma can be blunt or it can be penetrating, basically a shot or a gun wound. Third type is iatrogenic, which may be post-catheterization, which mostly occurs. It could be post-interventional procedures, it could be post-diagnostic procedure, basically any type in which we try to get vascular access, it can cause it. And lower limb extremity surgery within proximity of the major vessels, then this can be a major operation such as a hip replacement or something like that. Malperfusion is another cause. So malperfusion, we're going to be talking about aortic dissections later on, and other than that, it's isolated peripheral arterial dissection, though peripheral arterial dissection does cause this at a more smaller location rather than a whole limb. It can just affect the toes or the fingers. So we're going to move on to the mechanisms of thrombosis. Next slide, please. So, sorry. So out of all of these, I'm just going to cover the things that are more major. So the first thing we're going to talk about is atherosclerotic plaques. So thrombosis of a previously patent stenotic artery. So these are going to be open before. These are well-known complication of it. So in atherosclerosis, basically because there's the thinning of the vessel, basically decrease in flow over time. It's mostly chronic, but then again, because it takes its time to get slim, there are many collaterals forming at that area. So even if there's a block over there, symptoms might not be as pronounced as they are in the more acute phase, where there's a healthy vessel and that gets blocked. So this occurs mostly by two different mechanisms. One is progressive narrowing, and the second is the interplaque hemorrhage, which causes local hypercoagulability. So clinical manifest. So we're just going to go on to the next one: congestive low flow states, congestive heart failure, hypovolemia, and hypotension. So all three of them cause a slowdown in circulation rates, and that causes and that leads to a hypercoagular state. So at any time, there's a most likelihood of clots forming, and this could further cause ischemia if one of these clots breaks down and is transferred over to one of the distal limbs. Third one, hypercoagulable states. This can be therapeutic as well as this can be due to therapeutic hypercoagulation, or it can be generally due to a genetic disorder or something like that. But this causes recently, we've had some of these patients with acute essential thrombocytosis coming in with hemorrhages and ischemia. And next one is vascular grafts. Now, this is basically progression of the disease in which you already have some type of like some type of bypass, like a fempop bypass, and the graft which is present over there, it just gets thrombotic and it causes the block further on. Intimal hyperplasia. So the intima is the innermost lining of the vessel, and if there's hyperplasia in this section, it basically blocks out the whole artery. Then we're going to talk about arterial plaque rupture. Now, this is when there's a plaque already present and that just ruptures it flows off down to some of the one of the distal limbs, and that causes it. That may cause it. Some other causes which might not be mentioned over here in such detail are an aneurysm, which was talked about before. So this can cause profound or limb extremity, and this is mostly associated with popliteal artery aneurysms. Distal embolization can occur, and because of that, the aneurysm sites, ischemic complications are less common, but they have been reported. So the rest on the other side, we can see some other more common, less common causes. Aortic dissection, we just talked about that. Trauma, we had a brief overview of. So if we need to talk about any more of these, feel free to ask a question and we'll answer that, and I'll answer that later on. So if we go over to the next slide. So embolism. So from the term embolism, it means, so what do we understand from embolism basically? That means that the origination of the thrombus was at a different point. It breaks off from its parent source and it flows down with the rest of the vessel, flows down the vessel and causes a blockage down the line. So the most common cause of this is atherosclerotic heart disease, and this does cause atherosclerotic heart disease. This is mostly in cases of hypercholesteremia where there's a plaque present, and it tends to just break off from that point, flows down, and causes a blockage somewhere down distal, mostly in the calf regions, where another cause would be, and mostly in the plaque region. So I'll just keep it towards this, keep it brief. Acute myocardial infarction, we know that's already caused by a thrombus, but that thrombus can further flow down and cause ischemia in one of the upper limbs or the lower limbs, though they're more common in the lower limbs. And arrhythmia. So arrhythmias, mostly some arrhythmias like atrial fibrillation, they require some long-term vascular, long-term coagulation. So in these cases where we're not getting our INR targets, there's hypercoagulability, and usually due to this abnormal movement of the heart, a small thrombus is formed, and this thrombus may migrate from that region. Valvular heart diseases. So like an arrhythmia, valvular heart diseases, there's basically a turbulent flow which is caused, and that normally is the source of the embolus in most of these valvular diseases. Don't start it. We can talk about that later on. So a bacterial thrombus may be another cause of this as well. If we're talking about artery to artery, we already spoke about an aneurysm and atherosclerotic path. Then idiopathic, unknown causes, they just happen. They could be post-trauma or something like that. If we go down to other causes, there can be an air embolism, amniotic fluid embolism in pregnancy, usually in the 3rd trimester, fat embolism, which mostly follow breaking of the fractures of the large bones, like the femur, Malignancy is always a risk factor. Some chemicals and drugs also cause an increase in the hypercoagulability states. So cardiac causes account for about 80 to 90% of these, 80 to 90% of these embolisms. Next slide, please. So here's a table which basically gives us a brief outline of how these two are different. So sources in embolism, the source may be frequent. We might be able to detect the source, but in thrombosis, we most likely we aren't able to know where the thrombus was mostly formed, because usually where it breaks off from, it causes blood flow at that region. Onset-wise, embolism is sudden, thrombosis is acute site, and embolism usually affects normal vessels. These vessels are usually not diseased. However, thrombosis usually occurs on vessels which are already affected with the previous disease, such as a stenotic vessel or a calcified vessel, or basically any vessel with atherosclerosis or any type of narrowing may cause it. So these are more common in older age patients. If we talk about previous history, there's usually a known embolic source, such as an arrhythmia or any other situation which may cause it. And likewise, thrombosis. So in thrombotic cases, there might be, because of the pre-existing condition, it's always chronic. The chronic symptoms are present, just like intermittent claudication, but at the same time, it's acute and chronic. So these symptoms might not be as pronounced as they would be in embolic ischemia. Findings: normal pulses are unaffected, and there's evidence of peripheral artery disease. This likewise is because of the same reason that in chronic cases collaterals develop, which help in blood flow. So even if the main vessel is blocked, there's still collateral flow to that vessel, so symptoms are less pronounced in that. Embolic ischemia might occur at multiple sites, thrombotic at a single site. And on angiography, you might see multiple occlusions in embolic cases with no collaterals. And I mentioned before, there might be diffused atherosclerosis and collaterals present. So if we go on to the next slide. So that was mostly about non-atherosclerotic causes, but if we talk about, and now we're going to talk about non-atherosclerotic causes. So this might be due to arterial trauma. Arterial trauma could be a car accident, could be blunt force, could be an injury, penetrating football injury, anything like that, which could cause trauma to the arteries. Vasospasm, drugs, low flow states, cardiogenic shock or sepsis, vasculitis, hypercoagulable states, aortic dissection. We're going to be talking about this later on. And external arterial compression, which could be with popliteal cysts or artery entrapment syndromes. And iatrogenic, this is arterial catheterization. This is basically due to a medical procedure. Exactly. So can anyone tell me what the 6 Ps are over here? 3 of these, you're going to notice. 3 of these, the patient is going to tell. So does anyone have any idea about these? I think everyone's more, yep, pulselessness and all of those. Yep, there's pain as well. Pallor. All right, so basically we all have an idea of what these are. So they're basically, these are very important to identify, and they basically are pain, pallor, poikilothermia, which is basically persistent, perishingly cold limb, pulselessness, paresthesia, and paralysis. So the things you're going to feel, or the patient would feel in this case, would be pallor, perishingly cold, pulseless, and the patient says he feels pain, paresthesia, and paralysis. Now, if we go a bit into the detail and we find out why these happen, so we're going to start off with pain. So the pain, that's basically associated with ischemia. Now, this pain is usually located distal to in the extremity, and it's usually below the level of ischemia. So if the ischemic part is sometime in some point in the mid thigh, you're going to feel pain below that point. And this pain basically progressively increases with duration of the ischemia. And the most important thing is that later on, like after some duration of ischemia, there's a likelihood that the pain just goes away due to the nerve cells in the end dying. Second one, perishingly cold and pallor. Both of these are related to skin changes. Now, because of this, the skin perfusion is affected, and the skin perfusion is affected, and what's going to happen is there's going to be a mottled look with delayed capillary filling. Now, in this situation, the skin of both the affected limb and the other limb, the healthy limb, should be inspected, and both should be compared. Their temperature, the color, and the capillary refill time. This helps differentiate between chronic and acute cases, basically. Second one, next one would be pulses. So it usually manifests with severely reduced pulses and normal pulses in the contralateral extremity. And this basically suggests an absence of chronic arterial occlusion and suggests that an embolus is the etiology of the disease and not a chronic cause, not more of a chronic cause. So the rest of the findings are related to a neurological examination. Now, these would cause subjective sensory defects such as numbness or paresthesia, which is basically an early sign of nerve dysfunction secondary to ischemia. Major loss of sensory and motor function, which is basically paralysis, is basically an indication of advanced ischemia, and usually at this time things don't look so well for the limb. In the lower limb, there might be the lower limb, the anterior compartment would be a bit more sensitive to ischemia and sensory defects as compared to the posterior compartment. And it's also the first neurological sign of acute vascular insufficiency. So can we move on to the next slide, please? So we just explained the 6 Ps. Here's a brief outline. So pallor, an early finding is that the limb would be pale. A late finding would be fixed cyanosis or mottling. Cyanosis basically means that ischemia has set in. We go to the next slide, please. Perishingly cold. This is due to reduced blood flow. Pulselessness. So as I mentioned before, both limbs have to be compared. Both limbs have to be compared to ensure this is an acute or chronic case, because in chronic case, the pulses will be diminished on the other side as well. Capillary refill time would be slow, and bounding pulses would be present more proximally. Next one, please. Paresthesia. So this is progressive, basically. It's initially you'd lose light touch sensations, then vibration, then proprioception, deep pain, pressure, and in the end, you won't feel anything at all at that point. Next one, please. Paralysis, like I mentioned before, it's a late sign. Fine movement is affected first, and rigidity basically when rigidity sets in, it means that at that point, damage is irreversible, and you'd most likely have to head over towards amputation. Next slide, please. So first 6 hours are very important for this. And basically, we have to manage the case as soon as possible for a better outcome. So let's move on. So investigations. So basically, because this is a diagnosis mostly based on clinical history and investigations, getting these investigations is extremely essential. A full blood count, CK would be increased in this due to muscle damage, lipids, renal function, and HbA1c, which gives us sort of a hint towards what might be causing it. And we'd also have to investigate hypercoagulability, which includes D-dimers, ferritin, your PTA, PTT, PT, and the ratio. So when we go into diagnosis, we're going to talk about what imaging modality we should be used. So the type of vascular imaging basically is based on availability and of what's available at that time. With patients with viable or marginally threatened limbs, they're usually candidates for vascular imaging. That means that these patients in which they're not hemodynamically unstable would prefer something like a CT angio or a catheter-based angio. But patients in which who are hemodynamically unstable, these have to be treated in a surgical suite and they might require open repair. So less invasive investigations are Doppler ultrasound and duplex ultrasound. Angiography, this is mostly based on the hemodynamic status of the patient. Ankle brachial pressure index, this is another indicator which basically helps us identify the cause. So the next slide, please. So classification of this is basic. The classification followed for this is the Rutherford classification. It's divided into 3 classes. The first class is in which there's no immediate threat to the limb. This is basically sometime in the beginning where there's no sensory impairment, no motor impairment. On Doppler ultrasound, you can hear both venous and arterial pulses. In class 2A, this is when time starts becoming short and it's marginally threatened at this time. So, and sensory impairment might be minimum at this point, but it started setting in. There's no motor impairment and it's unlikely you hear an arterial pulse in this. Class 2B, however, it involves the forefoot plus pain at rest. Motor impairment, you might have motor impairment, you might have to stop, your limb might hurt at this point, and you can't hear arterial Doppler pulses in this. Venous pulses are present up to this point. In class 3, however, it's an irreversible point at this point. You won't feel anything in the limb. Paralysis and rigor set in, and you won't get any arterial or Doppler pulse, any arterial venous pulses in this, even if you use a Doppler scanner or handheld Doppler. So this is another representation of the same thing before, but this is a bit more general than that. So over here, sensory loss would be in 2A would start at the toes. In 2B, it would be beyond the toes. We're talking about the toes over here because that's the first place where they would be affected because blood supply sort of tapers off at these points. So that's where you'd get the initial symptoms. And in 3, there's profound anesthesia below the point of ischemia. And pretty much the rest of this is the same over here. So we move on to the next one. So here's a brief summary of management. So like I mentioned before, that because this is more of a clinical, you have to identify it clinically before you can go ahead with other investigations. If you don't identify it, you can't proceed with the investigations. And there are some differential diagnoses which do make it a bit hard to identify, although in most cases, it's basically a spot diagnosis. So the most important thing is the history, followed by the examination, went over both, and the investigations. Next part is staging, and the third part is management. So management is basically dependent on the stage of disease. We're going to give heparin to all of them. We're going to give heparin to all of them, and we're going to try to dissolve the clot at that point, see if we can if we can get blood flowing again. So for one, we should likely go for early intervention, and this is when we have options present. But beyond this point, our options start decreasing. In 2B, it's going to be an arteriography, and then we're going to make a decision based on our findings. In 2B, this is when irreversible causes start setting in, and this would need emergency revascularization, which could be on the surgical table, like you can get a fempop bypass or any type of bypass graft in this. And third, this is when there's profound damage and you just have to wait for a line of demarcation and amputate from that point. Next slide, please. Some of the complications, it would be a compartment syndrome. So for a compartment syndrome, you'd basically have to do a fasciectomy. Rhabdomyolysis, this is caused because of decreased oxygen delivery to the muscle cells, which cause them to break down, leading to myoglobinuria and AKI. AKI further causes hyperkalemia and metabolic acidosis. Cardiac stenting, obviously this forms a sort of septic focus, which could put you in cardiac shock, and ARDS, which could be caused by backflow pressure and leading to right heart failure and pulmonary edema, which causes the ARDS. Next slide, please. Outcomes. So mortality is quite significant in this. You have a 10 to 15% mortality, but usually it's based on the stage at which you catch the disease. So 10 to 15% would have major bleeding and they would require transfusion or operative intervention. 20 to 30% require amputation. This just shows that catching this is more earlier. If you have 20 to 25 to 30% people requiring amputation, it just shows that delays in basically investigation and treatment have a more poor outcome. Now, the fasciotomy, this is usually caused due to the compartment syndrome, and we can see that prevalence is also present over here. And renal injury shows there's always muscle deaths of 20% people have renal injury. That shows that it is quite important to catch this early on. Next, please. So the next thing we're going to be talking about is an aortic dissection. Now, the first thing to clarify over here is that an aortic aneurysm is not an aortic dissection. Basically, an aortic aneurysm is a bulge in the aorta, which can predispose you to a dissection. And a dissection is basically the tearing of the vessel wall, the innermost vessel wall, or the second layer or the third layer. So in UK, screening is offered to all men and women above 65 or 70. Now, if we move on beyond this, sorry. Next. So basically, it is relatively uncommon, but it presents acutely, and it can have a catastrophic illness and severe chest pain and acute hemodynamic compromise. That's why it's an emergency over here. Early and acute diagnosis and treatment is crucial for survival. So the tear in the wall of the aorta, allowing blood to flow where it usually doesn't. This basically means that it's flowing into the intima and forming a balloon over there. It might burst at one point, causing a ruptured aortic dissection. So initially, the innermost layer is affected, but the medial layer comes to the high pressure and it causes a longitudinal tear or another type of tear, which we're going to go on in detail further on. Separation of these two create a false lumen, and there can be further tears, allowing for more exit and entry sites of the blood. This is basically complex, and we're going to be talking about this in the types in the next few slides. We'll move on to the next one. Okay, so this diagram over here basically shows the three layers of the vessel, the adventitia, which is the outermost layer, the media, the innermost, and the intima. So basically the tear is initially in the intima, and the media and adventitia basically first work to hold hold the blood in place, but later on, due to high pressure, the media also tears, and the tear can also proceed to the adventitia and cause a bleed basically into the body. Next slide. So this is a better picture which shows how this is done. So we can see over here that the intima breaks off and it causes a bulging in the media over here in the last one. First, you have a healthy vessel, then the rupture of the intima, and then a ballooning due to dissection of the media. So when we go over to classification, I'm gonna speak more about DeBakey and Stanford type as opposed to the Crawford type, because it's used more often, the Stanford than the DeBakey type, the one which is on the left side. So it's basically based on the anatomy of where the dissection is taking place. So in the DeBakey type system, it's basically based on the origin with and there are three types basically. Type 1 is originating in the ascending aorta and propagating to at least the aortic arch. So it just involves at least the aortic arch, doesn't go beyond over there, which I think is shown in type 2 over here. Type 2 is confined to the aortic. This is type 1. Basically, it can involve the whole ascending and descending aorta. Type 2 is just involves the ascending aorta, and type 3 is beyond, is originating in the descending aorta and is basically extending distally or proximally, but it doesn't get past the left subclavian artery. Stanford type, it's also based on the same thing. Type A is a tear anywhere in the first zone, basically anywhere below before this what do you call it? I'm sorry, the term just basically left my mind, but it is basically we can call it zone 0 right now. When it just comes back to me, I'll just tell you what it is. And then anything beyond zone 0 would be type B in this. So we're not going to aneurysms. It's basically Crawford type, depending on the location and its relation to the diaphragm. If we move on, let's go to the next slide, please. So classification is acute, subacute, or chronic. Acute is within 2 weeks. Subacute from 2 days to 2 weeks to 90 days, and chronic is beyond 90 days. And it's almost always type B. Next one, please. Epidemiology, mostly it's in advanced ages, though it can happen in lower ages. And when it happens in younger people, symptoms are less pronounced. When it happens in older people, when it happens in younger people, symptoms are present more. When it happens in older people, they don't have too many symptoms, or the symptoms are not as obvious as in younger people. Male to female ratio is 5:1, meaning that it's more present in males than females. And if it's not treated, mortality just tends to rise. It already has a high mortality rate, but if it's not treated, the mortality just continues to rise. So we're going to talk about some high-risk conditions which can predispose to having this. The first one is hypertension, and this is the most common cause. Mostly 76.6% of cases have hypertension. Second one is atherosclerosis, hypercholesteremia, but the more important one in these are connective tissue disorders, which account for mostly all the other types. The rest of them are still less. Cocaine use, heavy weightlifting, pregnancy, first stage of labor, all of these are also contribute to it. Trauma is a more rare cause, though. The reason why genetically mediated connective tissue disorders are important in this is because these are the types which are mostly, these are the types which mostly get surgical intervention as opposed to the other types. Treatment is also based on the location, so that's also why the classification is important. If you move on to the next slide, please. Signs and symptoms. Okay, now the sign and symptoms basically depends on the age and the type. So pain, that's the most common symptom, and it occurs in over 90% of patients. And the location of the pain, that is more important. It could be the chest or it could be the back, though there's also a chance that it could be painless as well. And painless dissections usually occur in people of older ages. And also in this age group, the ascending aorta is more affected than the descending aorta. Talking about the causes again, diabetes, hypertension, these are one of the most common types of causes. In type B dissections, all right, we're gonna go back to this. All right, acute pain. So the most common type of presenting pain is a sharp knife-like pain. And this is the reason why most of the people come to the ER to describe this pain as a sharp and knife-like, and they go and they basically reach the ER as soon as possible, within minutes or hours. And they describe it as an extreme pain, and they haven't ever experienced this type of pain. It could be the only symptom, or it could be associated with syncope or a cerebrovascular accident, or an MI or heart failure. But when the pain is described, it's usually in the anterior chest if it's the ascending aorta, or the back for a descending aorta. It could also cause angina, and MI, or a new murmur. The murmur is mostly a diastolic crescendo murmur, and with a white pulse pressure. It could also cause hypotension along with it. The type of it may have valvular involvement, and that would be aortic valve regurgitation. And this occurs in about half to 2/3 of patients with ascending dissections. So the murmur is related to the aortic dissection, is commonly heard above the right sternal border. Pulses is the next thing which we have to look for, because there always might be a pulse defect. There might be a considerable variation in the systolic blood pressure in both arms. And though this is more common, the variation is more than 20 mm of Hg, but it's more common in patients with ascending aorta involvement rather than descending aorta involvement, which is 30% of patients have this in ascending aortas, and in ascending aorta dissections, while 9 to 21% in descending aorta complications. And if there's an involvement of the aortic arch, it may mimic a stroke and cause GCS defect, as blood flow to the brain is hindered in this type. Next slide, please. Next slide, please. Yeah. All right, so I'll just talk more about the signs and symptoms. Hypotension is another sign which may occur, and this would be present at initial presentation. The patient might be just hypotensive, or he might be in shock, and this is usually due to ascending aorta as compared to the descending aorta. And in the descending aorta, hypertension is more common. It can lead to a cardiac tamponade from a rupture, acute aortic valve regurgitation, myocardial ischemia, or a hemothorax. Can we get the next slide, please? Okay, so the one before this, investigations. Okay, so before we get to a CT scan or orthography or a TTE or an MRI, we always do an ECG over here. And it's less helpful when if the dissection leads to coronary ischemia, but it's still worth doing it. In about 30% of the cases, you'll get non-specific ST or T wave changes. And in 42%, you might get some the features of left ventricular hypertrophy and ischemic changes in about 15% of the patients. If you do a simple chest radiograph, it might also help rapidly differentiate the various causes of the chest pain. You might be able to rule out some other causes of the chest pain. But then again, because this is time sensitive, the whole thing is time sensitive. It's always better to go on to. It's always essential to move on to the more specific and sensitive investigations. Sorry if I missed any questions. I'm just going to answer them at the end. We'll get some time to do a question answer session then. So CT scan, it's very sensitive, 94% and very specific. However, because this takes some time, and during this time, the patient has to be in a machine. If he is hemodynamically unstable, this is not what we're going to prefer. This is what we're going to prefer if the patient is still hemodynamically stable. Aortography, it's 88% sensitive and 94% specific. This is not used that often. TTE, although a bedside TTE, this is used more commonly, and it can be used in non-hemodynamic patients who are not hemodynamically stable. It can detect coronary artery involvement, evaluate the distal ascending aorta and the proximal arch. MRI is gold standard. However, MRI is a time-consuming process, and this can't be used too often if the patient is hemodynamically unstable. Some lab investigations that might be helpful would be a D-dimer. And it is a potential serum marker for acute dissection. However, because it also represents many other different things, it's not used specifically for a D-dimer. Now, if we go on to management, so management basically depends on the cause. If it's hypertensive, which is the cause, our main goal of management would be to reduce blood flow and blood loss at this point. So first line of treatment would be rate controlling beta blockers, calcium channel blockers, and analgesia. Pain is a big factor in this. So analgesia is always used, and we shouldn't. And if the patient comes in, he's complaining of pain, it's always worth giving the patient some pain relief. We don't have to wait to take the whole history before we give the pain control. Reducing the heart rate, reducing the hypertension, that's always essential in decreasing the blood loss, and that leads to a better mortality. But despite all of this, mortality is still very high. Bed rest is very important. The more you move when you have an aortic dissection, there's more chances of it to rupture. ICU care, monitor for an HB drop. Though it's not just monitoring for an HB drop, because if you're getting a drop in the HB, it means that he's bleeding internally. So this would need to be investigated more, and close surveillance, which you mostly get in the ICU. Other than this, there's a clinical triad which you guys should be aware of. So there's usually abrupt onset of thoracic and abdominal pain, which is sharp, tearing, or ripping in character. There's a variation in the pulse. There could be an absence of pulse in a proximal extremity or a carotid pulse, or a blood pressure difference, and mediastinal aortic widening on the chest radiograph. So the other thing is the probability, and the next thing is that the probability of a dissection related to the presence or absence of the following should be also taken into account. That if it's an isolated pulse or blood pressure differential, presence of mediastinal widening. So isolated pulse or blood pressure differential, this was seen in more than 83% of patients. Presence of mediastinal widening was in 39%, and pain alone was present in 31%. So if we get any of the three, it's always worth investigating for aortic dissection. Next slide, please. So now we go to surgical management. So basically, there are two types. One is type A, one is type B. Type A usually involves the ascending aorta, and type B usually involves the thoracic and abdominal descending aorta. So type B, because the management for type B is usually just medical management alone, though there is some surgical intervention for this, in which we might bypass the graft or some stenting, but oftenly the mainstay is medical management alone. In type A surgical management, there usually is intervention. Intervention is more common if it's related to a genetic condition. Other than that, for type A, endovascular repair of the aortic dissection is our most common modality, and open if there's extensive disease present. Next, please. So here's basically what we do in a thoracic endovascular aortic repair. Here's the stent, here's the aortic dissection over here. I know it looks like an aneurysm, but this isn't an aneurysm. It doesn't show the layers of the wall, but it's basically in the middle layer over here. So a stent is placed, which bypasses the area of dissection. Next slide, please. And this is surgical repair, where, as you can see, this area of the dissection is completely removed, and surgical grafting is done over there, which bypasses the whole layer and basically repairs the whole vessel. Next, please. Mortality is usually very high in this. 20% of the people die en route to the hospital, and in hospital there's a 30% mortality rate of type A and 10% of type B, and there's a 65% 5-year survival rate. So it just shows that outcome is pretty poor in these cases. So the last topic is cervical artery dissection. Now we already know what dissection is, so we'll go on to the cervical artery. There are basically 4 main arteries that supply blood flow to the brain: 2 carotids and 2 vertebral arteries. The carotids, though they're internal and external, ICAs and ECAs. Second one are the vertebral arteries, which are located in the back of the neck near the spine. And you can't feel these on physical examination. We all know they're made of 3 layers, and dissection occurs when there's a tear in the artery wall, which causes blood to leak. Now, because of the location of these arteries, symptoms are mostly related to stroke type cases, where you might get symptoms of stroke in these. And again, because of the location, outcome is also pretty much poor in this, though it may be good it may be okay depending on the vessel which is included. The splitting, so splitting of the arterial wall of the carotid or vertebral arteries. Splitting could be because of stenosis, which causes which can be due to a hematoma between the intima and the medial layers, or an aneurysmal dilation, which may lead to a hematoma between the medial and adventitia, which causes narrowing and could lead to cerebral insufficiency. It's a common cause of stroke in younger patients, basically in the age group of 35 to 50, and 20% of strokes occur in those aged below 45. Incidence is 3 in 100,000 per year. Next slide, please. So classification. Internal carotid artery dissection, it could be extracranial, it could be intracranial. 70 to 80% are extracranial. That means these usually happen before it enters the cranial cavity, and the other two are, and 15% in the intracranial. Likewise, vertebral artery dissection could be extracranial and intracranial. There's it's 3 times more likely that dissection occurs in the internal carotid artery than the vertebral arteries, and external cranial dissections are more common than intracranial dissections because the external cranial cranial parts of the arteries are more mobile and they may be damaged more. It's more likely that they be damaged. Next, please. So we talk about risk factors. Now, risk factors may be genetic, environmental, or other. So some risk factors may include infection, high blood pressure, migraines, smoking, birth control pills, alcohol use. And if we talk about genetic, it could be Eagle syndrome, which is pretty rare, fibromuscular dysplasia, Ehlers-Danlos syndrome, Marfan syndrome, homocystinuria, alpha-1 trypsin deficiency, osteogenesis imperfection, cystic medial necrosis, and basically so on. Next, please. So even though some are asymptomatic, pain is basically the most common cause. Pain is basically the most common symptom as usual in most of these. This is due to the distension of the artery, which stimulates the pain, receptors, and a constant ipsilateral head or neck pain so it's going to be ipsilateral in nature, the pain. It's going to be on the same side of the dilatation or the dissection. And like I mentioned before, that this does have an impact on the cerebrovascular side of things. So there could be a partial Horner syndrome. And the rest of the symptoms, apart from the anhidrosis, you'll still get meiosis and the rest, cranial nerve involvement and stretching of the nerves, ischemic manifestation, amaurosis fugax, and other stroke symptoms. So amaurosis fugax is basically an eye symptom. You might also get pulsatile tinnitus, which is basically one of the diagnostic findings in this. So you'll get tinnitus, but it'll be pulsatile in nature. You'll be able to feel or hear the pulse in your ear, and that will be mostly on ipsilateral in nature. So on the side of the dissection, you're going to be hearing this. So stroke is one of the most common presenting factors of this, and features of the stroke, you might develop these features just after the symptoms begin, and basically. It can affect your taste, it can affect your vision, it can affect your hearing, and it usually causes a headache, neck pain, or face pain. So that's basically just a quick summary of the signs and symptoms. So now we're going to be talking about the internal carotid artery first. So basically, if the dissection bursts through the adventitia and it's in the intracranial section, it could cause a subarachnoid hemorrhage. It can also act as a space-occupying lesion, and it has a very high mortality, 75%. Angiography is difficult because angiography it's not difficult performing the procedure, but interpreting the results is the more difficult part because you won't get any specific features of it. Next question, next slide, please. So we know the vertebral arteries, they follow the spine. So the most common cause is neck trauma. The neck is most mobile at the C1 to C3 location. That's the most normal, and that's the site, and that's the most likely site of injury. Extracranial dissection occurs more in females than in males. It presents as neck pain, dizziness, vertigo, double vision, ataxia, dysarthria, Wallenberg's, and stroke. Basically, these can also be symptoms of SAH as well. Intracranial is more common in males than females, and they present with a proper SAH, brainstem stroke, or an aneurysm, which presents as a space-occupying lesion. So you get symptoms according to the location of the dissection. Next, please. So diagnosis. Diagnosis is basically MRI of the brain or neck, MRA, cranial CT, cranial CT angiography, or Doppler carotid and ultrasound. Doppler ultrasound, this is now being introduced more in practice. Initially, it was just a CT angio or an MRI or an MRA. DCA is another common procedure, but DCA is mostly done following a stroke when you have to coil or embolize the aneurysm. Doppler ultrasounds is now are being used more often now. They're non-invasive and they have a good sensitivity. MRI, because these changes take some time to become evident, it's mostly sensitive 2 days post-event. If you do an MRI, mostly as soon as the patient comes in, and you might even get a normal MRI at that point. Next, please. Management. Management could be medical or but it's mostly surgical. Medically, it's just anticoagulation. That's heparin and warfarin, and then antiplatelet. Surgical. It's surgical. Basically, it's the same management as an SAH, which depending on how extensive the dissection is. Aneurysmal dilatation, persistent high-grade stenosis. It basically depends on which stage it's at. It could be coiling, it could be embolization, etc. Mostly depends on the extent of injury that is caused in this. So it could be thrombolysis if you've had a stroke, heparin to prevent blood clots, IV fluids, blood pressure medicine. Glycemic control is important in all of this. Usually patients are put on a lifelong aspirin or warfarin, and this medicine could be used for 3 to 6 months, but at the same time, it could be lifelong. Stenting or bypass are also common treatment modalities for this. So like I mentioned before, outcome basically depends on the lesion of the location and the duration of symptoms. How early you catch this, the better the outcome. Other than that, location-wise, if it's external, it has good prognosis because there's less intracranial involvement. And if it's intracranial, because there's effect on brain, it mimics the symptoms of SAH. It depends on how extensive it is and what type of deficits it's causing. That's the prognosis basically depends on that. If it's an extensive bleed, prognosis could be very poor. If it's still a small bleed, there is chance for recovery, but recovery is often a slow process. The recurrence rate is low though, and anticoagulation or antiplatelet, there's no evidence that suggests that that basically contributes to its recurrence. Next, please. Right, so do you have any questions about this?
Thank you, Bilal. That was excellent. If anyone has any questions that I haven't answered, please put them in the chat and we can try and answer them. There were some that I had written down, but I haven't got them to hand. Be really grateful if you could give us some feedback. So any feedback at all would be really beneficial for us as a kind of a teaching platform moving on. I'm just going to put the link in the chat.
All right, thank you, everyone. I hope that was pretty enlightening.
Thank you, Bilal. Thank you.
Thank you.
Dr. Addy, you've given me lots of questions that I can't answer all of them. So apologies if I can't answer them all. Thank you for your link as well. Here's a link to the feedback. Bilal, are you still there?
I'm still here.
I've got a question for you. There was a question that was quite high up. Do you know in predominantly right-sided heart failure, can pro-BNP be normal ranged? I'm not sure.
The drop in BNP.
Yeah, so the BNP in right-sided heart failure, I thought, my understanding is that it would usually go up, but I'm sure that there are anecdotal cases where it doesn't. But
So if we speak from if we say from a clinical point of view, most of the cases that we do get here in the ICU or we see in clinic, it's always raised. Though the raise, it could be moderate, it could be just like the drop could be around 47 or it could be in the thousands. So it basically depends on the extent of heart failure at that point.
thank you. Sorry, everyone. I'm just going to try again. Just give me 1 second. Try that, please. I'd be very grateful for your feedback if possible. Just going to plug a little bit of Medicine the Essentials whilst we're here. I'd be very grateful if you could follow us on YouTube. We're going to do a talk a week about sort of basics of foundation year doctoring. Every week we're going to do like an F1 or F2 survival series and hopefully give you some insight to what it's like to be a junior doctor in the NHS and some tips and tricks to make the transition from medical school to working. Oh, it says it's still not. I'm so sorry, guys. Just give me 1 second. Try one more time. Should hopefully work. Play one more time. There, fine. I'm going to stop sharing the screen just for a minute. I'm going to try and share the screen again, guys. 1 second. Try that. Hopefully that works. Am I presenting the QR code? Does it work? Brilliant. Sorry about that, guys. Thank you so much for telling me. Yeah, if you could give us some feedback, anything at all, good, bad. I thought that was a really great talk and it was really informative. And so those conditions are really important to recognize, especially if you're a junior doctor, and especially if you know how to sort of identify that there's a cold pulseless foot in front of you and you know who to speak to. I think that's really really important as a junior doctor, so you know when to escalate appropriately. Does anyone else have any questions at all, or any questions to Bilal? Any questions or any feedback that you'd like to give in the chat? So any topics you'd want to see immediately in the next couple of weeks? If not, you can just give us feedback through the QR link. Okay, guys, thank you again. Hope you have a nice evening. We're going to stop the recording now and we'll stop the talk. Thanks again. Have a good evening. Bye.
Thank you. Bye-bye.
Oh my God, what the fuck?